Thanks, David. I sort of have a similarly tall order that Maxine had, which is to try to summarize what's been about 20 years worth of research in a 45-minute period. And actually, it's an even bigger problem with this area because motivational interviewing is actually one of a number of what are called brief interventions for which there's about 40 years worth of research supporting their efficacy. So I'm going to try to keep it as condensed as I can. What I'm going to do is just sort of provide you some brief background on brief interventions. I'm not going to spend a huge amount of time on that broad category because I want to focus in a little bit more on a specific kind of brief intervention, which is called motivational interviewing. To get from one to the other, I'll talk a little bit about this concept of stages of change, which is a critical concept. There are really a variety of brief interventions that have been used with people for alcohol and drug problems, and they range from things that have as their goal the enhancement of motivation. Some have used very short attempts to build coping skills for people. Other interventions have focused more on conducting assessments and then giving feedback to patients right away to kind of heighten their understanding of the problems that they have and hopefully motivate them. And other kinds of techniques have used sort of straight, very brief educational approaches delivered by, say, a physician in a primary care setting or very direct kind of advice. So it's a very heterogeneous group of brief interventions. And again, I'm going to focus mostly on motivational interviewing. This is just a little bit of the history. This whole area of brief interventions got kicked off in the early 1960s with the work of Chaffetz, who was really focusing on using an empathic, respectful, concerned kind of counselor approach in intervening with people who were presenting in emergency rooms for alcohol-related accidents or problems and trying to get them to follow through on alcohol treatments. And they found that using this kind of more supportive, engaging, concerned approach led to anywhere between 10 to 15-fold increases in people making their way into alcohol treatment programs. Some research then followed that, which actually moved towards even more minimal interventions, if you can believe that, which were things like making supportive phone calls or supportive letter writing, again, to try to facilitate people's follow-up on important referrals that were being made. This work was sort of modified to some extent in the 1970s, with work conducted primarily in the United Kingdom by Griffith Edwards and other people like Nick Heather, where they really were comparing some of these sort of brief, again, models that were focused on advice and support delivered in a kind of a non-confrontational manner to people who are having problems with their drinking. Not necessarily alcohol dependent, but people that were really getting into some significant difficulties. And through the offering of some simple advice that was sympathetic and constructive and not sort of you need to get treatment for your addiction, they were finding that these interventions were just as effective as more intensive forms of treatment approaches. And then in this country, throughout the 1980s, really starting in 1982, 1983, when Bill Miller first started calling this motivational interviewing, Bill has really embarked on a systematic series of studies of this intervention that are really only rivaled by work that Maxine and others like Steve Higgins have done for incentives, where it's just very systematic, trying to look at different components, which are the pieces of the intervention that seem to be most effective. One particular slice of what they have worked on is this thing that is called drinker's checkup. And a lot of times when you look in the motivational interviewing literature and they'll refer to MI, they're really kind of talking about this drinker's checkup, which is a fairly straightforward intervention where there's an assessment process that occurs and then feedback is given to the client. Not necessarily advice one way or the other what to do with that feedback, but assessment plus feedback, which is a piece of motivational interviewing, but there's more to motivational interviewing than that particular slice. And then in the 1990s, with a project which hopefully people have heard about in here called Project Match, essentially Bill Miller and his group and other people from across the country took this motivational interviewing approach and attempted to manualize it for the purposes of a large-scale study on alcoholism and alcohol abuse. So what's also impressive about this area is that these are interventions that have been used across a variety of practice settings. So you'll see them used in emergency rooms, general practice, primary care centers, addiction clinics, mental health clinics, EAP settings, University counseling centers is sort of another one. And in each case, the effects seem to be promising. When Miller and Sanchez reviewed this really diverse group of brief intervention studies, they tried to come up with a listing. What are the common things that you see across these types of interventions? And they've summarized this with an acronym called FRAMES, where feedback occurs with the client, non-judgmental feedback, just providing information for people. Responsibility for change is emphasized as opposed to sort of dictating to people the need to change. Advice is usually given in many of these brief intervention techniques, and a menu of alternative change options as well. The therapist is empathic as opposed to confrontive, and the therapist's important goal is to promote self-efficacy or optimism, that if the client were to decide to make a change in their life, that they would have the capacity to do that. That said, a lot of the brief interventions ones, these very brief sort of advice-oriented ones, have tended to use these top four, I'm not going to jump, but these top four kind of FRAM pieces of it, where feedback, advice, and providing a menu of options. Where Bill Miller's approach has really moved with motivational interviewing is more into more of the stylistic aspects of doing these interventions, where there's a stronger emphasis on therapist empathy and what you do when you encounter resistance from a client, which is so normal. Right around the same time that Bill Miller was doing some of this work, was focused initially around smoking, developed this transtheoretical model around the idea of stages of change or readiness to change. Depending on the model that you look at, you'll see either 4 or 5 stages of change outlined. So I've put the 5 up here. Pre-contemplation is a state where someone's not considering the need to change. It's what kind of a disease concept model of addiction would kind of refer to as being in denial in a way. Contemplation is where the person is at least having some level of ambivalence about maybe they do have a problem, maybe they do, maybe they do not. Maybe they should do something about it. Maybe they should leave it alone. Determination is when the pendulum is switched a little bit more to the point where the client is feeling more ready to take some kind of change. Action is the stage where someone is starting to experiment with change, although they may not have achieved lasting change in that behavior. And then maintenance is the stage where someone has really moved into a longer-term phase of recovery. And the goal oftentimes with these brief interventions or with motivational interviewing isn't necessarily to take someone from pre-contemplation to maintenance, but to try to, through this technique and styles, to move people sort of up the ladder of change so that they are more ready to make a decision about that. These are the principles of motivational interviewing, and here you'll see sort of the E and the S of the frames that I talked about before: express empathy and supporting self-efficacy. Developing discrepancies is sort of a style or technique in which you're trying to get the client to look at kind of where their life is right now and where they'd like it to be and how they're going to get across that gap through decisions that they might make. Avoiding argumentation and rolling with resistance are 2 of the big contributions of this model as it was really evolving at a time where the treatment in this country was very much focused on disease concept or confrontational models, either through sort of 28-day programs or longer-term TC approaches. And as Maxine said earlier, it's sort of it's a kinder, gentler, concerned approach to the treatment of addiction. Just a couple more on background, and then I'll get into some of the outcome studies. The motivational interviewing approach has really evolved since Miller and Rolnick first articulated in the first edition of their motivational interviewing book, which I think was in 91 or 92. And they've just and they've revised it, and that came out I think 2003. And within that book and in the trainings that they've really been doing over the past several years, they've moved to another acronym. So you've got FRAMES as one acronym, and then the other acronym that they really use to drive home what they consider to be the core skills, or what they call micro skills, is this acronym called OARS, which I think it's a great acronym to help you remember this, but it's also a good, I think, visual acronym to help you think about kind of what you're doing with someone as you're in a kind of a rowboat with someone. Sometimes you're you're going to have both oars out of the water and just kind of let the boat drift a little bit. Other times you're maybe going to dip one in the water a little bit to try to steer it a little bit. And then when you know you've got the green light from the client to push forward for change, you've got both oars in the water and you're tugging. So it's a great acronym. But what it stands for is always open-ended questions, which are really designed to help the client explore the problem and that they may have and its full implications. Affirmations are really a technique that's it can be used for a variety of reasons, but oftentimes it's really used to promote that self-efficacy. So to really help the client realize that they have strengths, and if and when they get to the point where they decide they want to make a change in their life, they will have the capacity to do that. Reflective listening, and then what are either called summary reflections or summary statements, are techniques that are really meant to use to sort of track the language that clients are using in a session and to steer the client towards what's called greater change talk. There are other techniques that are used, and I put these up here because these are a little bit more, these oars are much more related to sort of the style that you would have in sort of being in a room with a client when you're working with them. Sort of listening to the language that they use, tracking it, trying to elicit change talk. There are other more kind of technique-y kinds of things that can be used that often involve worksheets, and these really came when Dr. Miller sort of turned motivational interviewing into that sort of manualized version of motivational enhancement therapy. And these are exercises that are designed to give personal feedback. Again, that's sort of out of that drinker's checkup model that I referenced before. A decision balance technique where you have people look at the pros and cons of using versus not using, stopping versus not stopping. Various techniques to try to elicit these self-motivational statements, and developing alternatives and options. And I'm assuming Charlotte Charlotte Chapman will touch on some of these in her afternoon workshop. Okay, I'm going to try to move through the outcome studies. And I've listed these pretty much in order of the amount of empirical support that exists in the literature for these different groups of clients. The largest literature for motivational interviewing, but also for this broader group of brief intervention techniques, is for heavier problem drinkers, people who may meet criteria for alcohol abuse but are not alcohol dependent or addicted to alcohol. Then the next largest group would be alcohol abuse or dependence patients, then drug abuse dependence patients, duly diagnosed, and then I'll briefly talk a little bit about some other health risk behavior groups. Again, the literature on heavier problem drinkers is not just motivational interviewing that I'm talking about, but are sort of a range of things, including this drinker checkup intervention where feedback and assessment is provided to people in a non-judgmental way. But there really is a wealth of research that indicates that brief interventions are more effective than no interventions, or when you put people on sort of a waiting list instead of going into one of these interventions. As importantly, and sometimes this is really astounding when you see the interventions that these brief interventions are stacked up against, that they do as well as more intensive interventions. So single sessions of sort of a 30-minute interaction will oftentimes do as well for engagement and for outcome as a 12-week kind of counseling that might get offered. These approaches are effective in a variety of healthcare settings, not just in traditional addiction treatment programs, but in primary care settings and emergency rooms. As you recall, the initial studies actually for some of these brief interventions occurred in the emergency room, and Carlo Di Clemente, who's at University of Maryland, Baltimore County, is doing work in sort of shock trauma units where they take that sort of opportunity of when someone has experienced something really negative related to their substance use and try to briefly intervene to see if this would be an opportunity to get someone into treatment. And then there's also a continually evolving literature looking at what are oftentimes called risk reduction approaches in college samples. And this is based on the idea that it's probably unrealistic to think that you're going to go with college students who are drinking at very high levels but may not be alcohol dependent and to go to sort of an abstinence model may not be a realistic approach for this group, but risk reduction may be. And so these models have been used. A lot of times it's that drinker checkup model that I was talking about, where you make the students aware of where their drinking is in comparison to their peer group, and kind of putting it out there, what are they going to do about that? So when you look across all of the studies in heavier problem drinkers, over half of them show some significant reduction in drinking. The thing that is really amazing to me about this is that oftentimes these gains are sustained at follow-up. So to actually see that a single session of a brief intervention, when you then look at 12 months later, people have still reduced their drinking, for me is kind of phenomenal. And very rarely do more intensive treatments yield measurably better effects. Again, this is for this heavier problem drinking group. So let me shift a little bit into the alcohol abuse and dependence group. There aren't a huge, in comparison, number of studies that have used motivational interviewing for alcohol abuse or dependence, but there are a number. Again, a lot of times what you'll see with these are, it's not clear if they're really motivational interviewing as Miller is talking about it now, or whether it's this more narrow focus on this drinker checkup model of assessment and feedback. But either of these approaches are found to be more effective than when someone is put on a waiting list for alcohol treatment. And again, that the effects tend to be no different for more intensive treatments. That being said, the effectiveness of these treatments really can be quite variable across studies and across treatment settings. But again, overall, you do see these reduced effects, reduced drinking behavior, as well as better retention and adherence. The big study of this was done for alcoholism with Project Match, in which a lower intensity model of motivational enhancement therapy, which involved 4 sessions, was compared to 12 sessions of cognitive behavioral therapy, or to a manualized version of sort of a 12-step model. And the motivational enhancement therapy had similarly positive effects as these. So there were no between group differences, at least at the point of termination. Some things turned up in follow-up. But again, there is, this is sort of second place finisher in terms of the amount of research that's been done in this area, but it's nowhere near the amount of research that's been done with sort of problem drinkers or heavy drinkers. And so we really need better understanding of some of the patient and program parameters and the amounts of treatment that are needed for this. And I'll return to this at the end of the talk, and then also in the forum that we have afterwards. So I wanted to shift to talking more about drugs of abuse or drug dependence. And here, in comparison to the alcohol treatment effects, there's much less consistent effects for the impact of motivational interviewing on drug abuse behavior. As you'll see as we go through here, the more consistent effects are actually in engaging someone in treatment who's sort of made an initial step in that direction. But again, the research in this area is kind of rapidly evolving, and I'll talk a little bit about the Clinical Trials Network study that we've been doing. So again, I'll just go through heroin, cocaine, marijuana, and dual diagnosis patients. Saunders et al. Found that motivational interviewing resulted in better retention and reductions in drug-related problems. That's not specifically a reduction in the amount of drug use, but a reduction in the amount of sort of associated life problems that they had as a result of their heroin or co-occurring drug problems. And that these gains were found at 6 months. And again, this is a single-hour session of motivational interviewing that was layered into a methadone maintenance program. Patients were assigned to either get this single session of motivational interviewing or to get a single session of what they called an education control condition. So again, this is really, again, one session right at the beginning of treatment, and you're seeing some retention and symptom reduction effects at 6 months is pretty remarkable. The findings are, there are a few more studies in stimulant patients, although these are a little bit more mixed. So I put up a couple of findings that have been more positive in this direction. Stotts et al. has found that 2 sessions of motivational interviewing reduced drug use and increased treatment adherence in cocaine abusers. And then Baker et al. Found that either a 2-session or four sessions of motivational interviewing doubled the rates of total abstinence and also reduced drug use in their sample of amphetamine users. And we've, in a small study that Kathy Carroll conducted in our shop, she was able to found that women who were referred through the Department of Children and Families, we were actually able to double their early retention or engagement rate in outpatient treatment with a single session of motivational interviewing in comparison to sort of a standard kind of assessment meeting that one would have. And then there are null findings that also exist that have been found by 2 clinical trials network researchers. These are not CTN studies, but studies that have come out. One is in the journal Addiction, I think, and the other one came out in 2003 in the Journal of Consulting and Clinical Psychology. So people have really, with a high level, investigators with a high level of expertise. Obviously, Miller developed the model. Yanni is one of the well-known supervisors of the approach. And they really, what they really found in both of the studies, that there was no effect on motivational interviewing on either treatment entry, treatment retention, or on substance abuse outcomes. Dennis Donovan's study randomly assigned a large group of substance abusers either to be on a waiting list for outpatient treatment, where they received a single session of motivational interviewing with some follow-up phone calls, or to not receive that motivational interviewing intervention. And again, there was no significant difference between the group with regard to their coming into treatment or staying in treatment. And then Miller's group looked at 2 different samples, one which was an outpatient sample, the other was an inpatient sample, and again, sort of randomly assigned people to receive early on in treatment either that additional session of motivational interviewing or not. And again, there was no differences on drug use, retention, or patient predictors. Oh, what I will say about this, one of the reasons for the null findings actually was that patients in both conditions did quite well. It was, I think in Donovan's study, the retention rates were somewhere in excess of like 70% for both groups, which is I've never seen in outpatient programs that I've been involved in. Usually you see about half people drop off after one session, and then you lose another half every few weeks, it seems. But they had about a 70% retention rate after 1 month. And you'll see that that's also came up in our CTN study as well. And likewise in Miller's study, both treatment groups did quite well. And when you have both doing quite well, it's harder, particularly for that single session, to really boost one up over the other. It's hard to do better than 70 to 75% retention within an outpatient drug-free program. With marijuana patients, Stevens has evaluated a 2-session version of motivational interviewing and found that it was better than a waiting list control for promoting abstinence, and also, just or if not more importantly, was comparable to a more extended version of treatment provided for marijuana patients, which was a 28-session treatment focused on relapse prevention. So this is a very similar finding to what you'll see in those alcohol samples, where these very brief interventions are better than nothing and comparable to something that's more intensive. And they found significant decreases in drug use, drug dependence symptoms, and related problems with the motivational interviewing approach. Going back to sort of a more mixed group of patients, and that just reminds me, I listed Donovan's study and Miller's study under stimulant abusers, mostly because that was the majority of their patients that was their primary drug of choice. But that was really a mixed group of people with cocaine, amphetamine, marijuana, and in Miller's sample, a significant number had heroin problems as well. But in a more sort of general polydrug group of patients, again, there have been some positive and some negative findings. Longshore found that a single session motivational interviewing improved treatment adherence and motivation to change. And Libcourt et al. Found that 6-group motivational interviewing sessions resulted in better outpatient treatment completion. And one thing I'll just sort of point out on this, which is related to some of the trends that you see in the substance abuse patient, is that the positive findings that you see for the polydrug patients here and for some of the other studies really will tend to center on whether or not people stay in treatment better with motivational interviewing than not. And the findings are not quite as effective when you look at reductions in substance abuse. These were the Null findings. They found no effect for motivational interviewing in comparison. And this was a Bob Booth's study. They were comparing motivational interviewing to a kind of a risk reduction kind of intervention to get people into treatment. And they found no difference between the two approaches for engaging people who were not in treatment. And likewise, Schneider et al. Found that there was no effect for a standard drinker's checkup, which is that model I was talking about before, when they compared it to a more confrontive kind of approach on entry into drug abuse treatment. And that's sort of another finding, is that it seems like the motivational interviewing is useful for people who first sort of make a connection into treatment, and it's good for sort of prolonging that treatment episode. The data isn't quite there for its ability to take people who are really not in treatment yet, sort of either on a waiting list or still out on the street, and getting them to get into treatment in the first place. And dual diagnosis patients, there have been several studies, a couple of which have people from our shop have been involved in, Steve Martino and Mike Pantalone, where they focused on motivational interviewing as a strategy to improve adherence in dual diagnosis patients. And these studies have found that single sessions of motivational interviewing do have positive effects for promoting adherence. And Daly et al. Used a much more intensive model in which they were integrating motivational interviewing with sort of a dual recovery focus for cocaine abusers who had co-occurring major depression. And they found that this program, which had 5 individual sessions and 4 group sessions, resulted in increased treatment attendance and abstinence, as well as reduced mood symptoms for people after they came out of a hospital setting and into an aftercare form of treatment. Okay, just quickly, this approach has been used in other populations, although it hasn't been studied as often. There are a variety of more sort of brief or skill-focused approaches that have been used for smoking, some of which are efficacious. I'm not going to talk about those in here. There have only been a few that have really looked at motivational interviewing as developed by Miller and their group, and the findings are fairly mixed. It's not a compelling body of literature supporting this use, at least sort of the single session motivational interviewing for smoking. The findings are a little bit better for studies of people who are particularly trying to lose weight or having cardiovascular problems. And there have been a couple studies by Smith and by Harlan that have found that anywhere between 1 to 3 sessions of motivational interviewing, when you add that on to sort of a standard either weight control or exercise program, tends to enhance those effects. Kate Carey and other people, such as Belcher, have applied these principles for people who are engaging in HIV risk behaviors. And there's really only been one study of this within eating disorders, and it did not find that motivational interviewing was better than a comparison treatment. So as motivational interviewing sort of repeatedly demonstrated its promise as an effective substance abuse treatment, the demand for training for these models sort of skyrocketed and far outpaced the knowledge of sort of what is the best way to go about doing these training things. So Miller's group out at the University of New Mexico developed a whole process which they call minting, which is another good, they're great at acronyms, I think. Motivational Interviewing Network of Trainers, and Charlotte might know more about this than I do, but I think the estimates are there's somewhere like 400 or 500 trainers across 30-plus countries. Hundreds of trainings on motivational interviewing are done each year. And again, despite this, there's almost a non-existent research literature on which training approach works best for this. In part because of that, but also because that's a criticism that you could say about any of the empirically supported treatments. NIDA issued an announcement where they were looking for research that was particularly focused on different ways of training in the behavioral therapies. And I believe there's at least 3 protocols that are getting started now that are looking at different training strategies for motivational interviewing. One which is looking at issues related to organizational change that might be needed to promote changes in practice. Steve Martino's doing one up in our state where he's comparing sort of manual guided plus supervision plus standard workshop training. And then Ned Nunez in New York is looking at sort of use of sort of computer technologies as a way to facilitate motivational interviewing training. And this was also something that we really paid a lot of attention to in the Clinical Trials Network study that I'm just briefly going to talk a little bit about after I just sort of let you know where sort of the current state of the knowledge is right now with regard to training. The 2-day training tends to be sort of the standard way. It's sort of the standard training that the University of New Mexico uses. And they do find that this type of training results in increased knowledge in motivational interviewing and satisfaction with training procedures. It does improve motivational interviewing skills, but it doesn't seem to be quite as effective at suppressing what people usually do, particularly suppressing what people usually do that might be antithetical to motivational interviewing. So it is good at elevating those skills, but it's still unclear, although there is some indication that these skills are lost pretty quickly over time unless you have some kind of ongoing supervisory process in place. And so, but again, this is based on a handful of studies, and even though people generally say you have to do the 2-day training, that a 4-day training like Charlotte is going to do is really a good exposure to it, but isn't going to lead to sustained changes in practice. But we don't really know the answer to any of those questions yet. We've just sort of focused in on the 2-day model, and it does seem to work. I'm going to skip over that one. Okay. Let me tell you just a little bit about the Clinical Trials Network study that we did, just because this was something that we really took very seriously, the issue of how you go about trying to set up a protocol that hopefully people would continue to engage in this practice once the protocol was over. And this was really the first Clinical Trials Network program which was focusing on a psychotherapy or a talk therapy that was targeting the frontline addiction counselors as the deliverers of the models. Maxine's and Nancy Petrie's incentive study had the research staff delivering the incentives, and the buprenorphine protocol typically had the medical personnel involved in this. So we were really trying to work with what is the largest provider group of addiction services in the country. And this was oftentimes the first randomized clinical trial for all of the community treatment programs, so research was a whole new piece of business for them. And we really had this goal of trying to affect and sustain changes in clinical practice, and trying to do this with a group of clinicians who were, for the most part, inexperienced with motivational interviewing, which is very different from some of the other research that I've shown, where they typically try to work with people who already know how to do motivational interviewing or are pre-selected for that because they report or show an audio tape showing that they have a style of doing therapy that would be consistent with that. And also, as sort of as a way to begin this bidirectional process, we had treatment providers and researchers sort of at the table from really start to finish, from protocol development, where the idea for this study really came from the community treatment programs. We decided early on that we would have 2 different protocols operating, one that was a single session of motivational interviewing and another one which was a 3-session one. And the reason we did that was that some of the clinics said we can't accommodate 3 sessions in the early phases of treatment, so rather than trying to have people change practice to accommodate the protocol, we tried to change the protocol to accommodate the practice, again with the hopes that if you do something like that, then maybe they'd be more likely to continue it once the protocol's over. We had people from the academic centers, from trainers from the ATTCs, clinical supervisors, counselors, all involved in the manual development process and the rating scales that we used for how we were going to be rating clinicians. And we had a system of training and supervision that was in place that I'll get to that in a minute. No, I'll get to it now. We had a system of training that was in place that, again, was meant to hopefully build in the dissemination piece of this. So We had in each of the different areas, we had an expert trainer who was trained by Bill Miller and Terry Moyers, who was in the general area where the study was going to be conducted. They trained someone who was, in most cases, a supervisor within the clinical program to be able to do this. Again, so someone with the kind of administrative or clinical supervisory authority to continue to supervise people with this once the protocol was over, and then also intensive training of the MET and MI therapists. These slides are in your handout, but I won't go through what we did with each person, but we'll just jump to the therapist and supervisor training and credentialing. Everybody went through this 2-day training, which combined didactic material, training exercises, role plays, videotape demonstrations, and then a certification process where they taped their early cases. These were rated by the experts on a scale that I'll show you in a minute, and then people were certified to do it. And then throughout the study, therapists and supervisors continued to get supervision so that people didn't kind of drift back to the way they were doing things beforehand. This is the system of monitoring that we use, or that we used for this study. Miller's group has a somewhat different system of monitoring, which is called the MISC. There are a couple of different ways that you can do these things, but what we essentially do is every person's session is audio taped. Not everyone is reviewed for supervision, but you sort of randomly select one. And what you have the supervisor do, or any rater do, is essentially do a rating to find out what therapist behaviors are being demonstrated that are consistent with motivational interviewing or motivational enhancement. And you can see kind of the ORs, open-ended questions, affirmations, reflections, and then some of those other kind of technique-y things, pros and cons, heightening discrepancies. And then what group of techniques are people engaging in that are inconsistent with motivational interviewing or motivational enhancement? And what we found when we looked at this, which is consistent with what other people had found, that our 2-day training was effective in training people on how to use motivational enhancement or motivational interviewing technies. They engaged in these more frequently than those clinicians who were providing the regular care. Again, this is, for me, kind of a remarkable thing because we took clinicians who had not had prior training in this. This was not an expert group of clinicians, at least in terms of motivational interviewing. It was a very experienced group of counselors. And we took that whole group and we essentially randomly assigned them to either get the training or to continue to do what they were doing. And the group that was randomly assigned to get the training did show over the course of the whole study, not just at the beginning, but over the course of the whole study, that they were doing more motivational interviewing. The interventions that we called antithetical to motivational interviewing, those sort of confrontation, psychodynamic kinds of things, we actually found were infrequently used in either condition, that the standard care clinicians didn't engage in much of these anyways. And then the motivational interviewing clinicians were also scored high on general counseling techniques. They were high in both conditions, but we included that because we wanted to make sure, we really didn't want motivational interviewing to de-skill people from doing the other things that are really necessary early on in treatment. I mean, you've got to orient people to the program, you've got to assess their substance abuse, so we didn't want to see that stuff go away, because then that's sort of an interference with what needs to be accomplished in an addiction clinic. So we didn't want that to go away, so we were relieved to see that, but we were hoping that we'd see somewhat difference in making those things go away, but they weren't all that common really in either condition. These are, this is a highly condensed summary of what our outcomes were for this study, but I just thought I would throw these up here. And that patients back up for a second. As I said, there were two different studies. One which is the single session, what we called motivational interviewing, which was conducted at Chesterfield Substance Abuse Services in Virginia within the Mid-Atlantic node. And Charlotte was the expert trainer on that and supervised people for that. So that was one of the protocols. The other one, and that one's done, and that's what I'm talking about here. Then the other protocol is the 3-session motivational enhancement therapy protocol. That one's still ongoing. We're still recruiting from a couple of sites across the country. So that data is not up here. So this is just the 1-session one. So what we found that patients who were assigned to the motivational interviewing completed more counseling sessions than when they just began the standard assessment process. And we looked at that sort of at 3 months into treatment. And we also found that at that 3-month point in treatment that patients who were randomly assigned to motivational interviewing were more likely to still be enrolled in the program. However, and again, significant, consistent with some of the prior findings, we did not find that motivational interviewing was any better than standard treatment in reducing drug abuse. We did find some trends towards reduced substance use behaviors in people who had alcohol as their primary problem. So that's, again, consistent with what the prior research had shown. But when you looked at the whole group in terms of their substance use frequency, you did not see those effects. Perfect timing. And if I can't get to all this stuff, this is part of what I would talk about in the forum. I just wanted to, a few slides and just sort of summarize what I see as some of the issues with regard to this, and you know, this can, people want to ask questions about this during the forum, that would be fine. In terms of patient parameters, the research suggests that motivational interviewing, if you're looking at reducing substance use, the effects are stronger for alcohol patients than they are for drug abuse patients. And it may be that, and this gets into the issue of symptom severity, that when you're talking about you know, treatments for people who are severely drug addicted with multiple psychosocial problems, that just trying to do a single session with them, unless it's sort of the early stage of a more intensive treatment program, is not likely to be enough. Patient subtypes, there's been some research to suggest that people who are somewhat more hostile or somewhat resistant tend to benefit a little bit more from motivational interviewing, but that has not been replicated across all studies. I think there was one that found that was the case, and a couple that have not replicated that. Likewise, for patient readiness, there have been some studies that suggest that people who are lower on the readiness to change do better with motivational interviewing, which would kind of make sense. But there have been some studies that have not replicated that either. And there really has not been enough research on looking at either gender differences or ethnicity differences or age differences. In terms of some of the treatment parameters, this is a literature, particularly if you look at the whole brief intervention literature, that is diverse in both what it does and also diverse in how they do it. So you will have some studies that are doing single sessions that last for 5 minutes. You'll have others that are doing single sessions that are more like 2.5 hours. You'll have other ones that are doing 6 to 8 sessions of motivational interviewing. And so some of the differences that you'll find between studies may have a lot to do with that and have less to do with the actual kind of content of what you're doing. And in studies outside of Bill Miller's group and a couple of other people's groups, oftentimes the delivery of motivational interviewing is rather poorly defined. It's sort of unclear how much they're really doing that motivational interviewing style versus doing the assessment and feedback piece of it. As I said before, for drug abuse research, the findings suggest that adherence and engagement are impacted a little bit more effectively than a symptom reduction. Mechanisms of action refer to the issue of whether or not motivational interviewing is changing or helping people change for the reasons that you think it's helping them change. In this case, what they've really looked at is whether motivational interviewing actually changes people's stage of change as a result of that. And again, there are 3 to 4 studies that find that that's the case, and then there's 3 to 4 studies that find that that's not the case. And again, I suspect it has something to do with the wide variety of treatment approaches that you'll see with these. And just a quick statement about this, where the evidence tends to suggest is that motivational interviewing does not seem to be, at least in drug abuse samples, all that helpful for the actual entry of people who are not in treatment yet and getting them into treatment. It is helpful for problem drinkers or heavy drinkers. It does seem to be the case for both alcohol and drug samples that it's very useful at these transition points. So someone has made an initial step into treatment and then lengthening that treatment episode, or someone's coming out of inpatient treatment and is transitioning down into aftercare or stepping up in the other direction. There's very little that's looked at things like medication compliance with regard to motivational interviewing, although people think that that would be helpful. And I've mentioned the issue of substance use reduction. One more. Okay. So across the variety of studies that have been done, motivational interviewing tends to show positive effects in well over half of all studies that have been evaluated. So it's one of the most heavily evaluated treatments for substance abuse. That being said, there is significant room for improvement of our understanding of what's going to work, and particularly what's going to work for people who have more severe addiction problems. A big area that I think needs attention is around the issue of training parameters and what is the optimal duration of training. Again, some studies you'll see like 1 hour of training that's provided for people, others will have sort of the 2-3 day training. So what are really the best training practices, and what are the best ways to get people to learn some of these core skills, or even understanding what are the core skills that you need to determine for these. One of the things that we've been really interested in is this issue of clinician education and experience. And a lot of the studies, as I said, have used people who are sort of pre-selected, who maybe have master's degree, doctoral degrees, have participated in clinical trials on this, and have used these as their therapists. And it may be that that doesn't tell us an awful lot about what it takes to really get people who are really working in the trenches, who maybe have a bachelor's degree, or maybe don't have a bachelor's degree but have a certification in something. What's the best training method that can be used to get them the skills that they need to do this? So I'll stop there.
Okay, thank you.